Good day, everyone, and welcome to today's program, Medicaid Expansion, New Opportunities for Public Health. At this time, all participants are in a listen-only mode. Later, you will have the opportunity to ask questions during the question and answer session. You may register to ask a question at any time by pressing star and 1 on your touch-tone phone. You may withdraw yourself from the queue if your question has been answered by pressing the pound key. Please note this call may be recorded. I will be standing by should you need any assistance. It is now my pleasure to turn the conference over to Ms. Jennifer Singleterry. Please go ahead, ma'am.
Thank you, Jackie. Thank you, everyone, for joining us today. We're happy you are here, and we're happy to share this webinar with you. Just before we get started, I just wanted to So my name is Jennifer Singletary. I'm the Director of National Health Policy at the American Lung Association. We're in the national office here in DC. And today I'm just moderating, and we really are here to feature our two speakers, who I will introduce in a second. The one thing I wanted to mention before we get started, our operator mentioned that you can queue up to answer questions by phone at any point during the presentation. You can also use the Q&A box that you should see on your screen to type in a question and ask that through the online. Again, feel free to do that throughout the presentations, and we'll get to the Q&A at the end. Also, it's great if you have a comment and not a question. We also want to get discussion going as well. So that is welcomed as well. So let me introduce the speakers. First, we'll have Andrea Callow. Andrea is a Medicaid policy analyst at Families USA, a national nonpartisan healthcare advocacy organization based in Washington, D.C. Prior to joining Families USA, she was a policy attorney at the Center for Medicare Advocacy, where she specialized in ACA implementation and policies affecting those dually eligible for Medicare and Medicaid. After Andrea speaks, we'll hear from Lindsay Nelson, who is the Coordinator for Community Development and Outreach with the Kentucky Primary Care Association, where she works with federally qualified health centers statewide, providing outreach and enrollment training and technical assistance. Lindsay also manages the contract with the state of Kentucky to provide in-person assisters to one of the 8 Medicaid regions. Lindsay serves as the chair of Kentucky Voices for Health Get Covered Kentucky Work Group and is co-chair of the Healthy Reentry Coalition of Kentucky. Lindsay graduated with her BA with a major in psychology and minor in philosophy from Gettysburg College and her master's in social work from Spalding University. So we're going to start out with a national perspective on Medicaid expansion from Andrea, and then get the perspective of a state that's really doing some great work around enrolling Medicaid expansion folks from Kentucky. So I will throw it over to Andrea, and Andrea, you should be able to move your slides.
Thanks, Jennifer, and thanks for everyone on the line. I'm really pleased to be with you today to talk about Medicaid expansion. It is an issue that my organization, Families USA, holds very near and dear, and we are truly committed to seeing all states expand Medicaid, and I'll tell you why in a little bit. But first, I just wanted to sort of get into the basics of what Medicaid is, who it serves, what it does, and how expansion is working. So just to give you a sense of what I'm going to be talking about, first, what is Medicaid? And that's actually a very complicated question to answer. So I'm going to give you the most sort of reductive, simplistic answer possible to kind of give you a flavor for what the Medicaid program is. Then how the Affordable Care Act affected the Medicaid program and what Medicaid expansion really means. It's a word we hear a lot about, or a phrase we hear bandied about, but sometimes we don't actually know what it means for a state to expand Medicaid. Then talk about when you do expand Medicaid, who are you giving Medicaid to? Who is this population? And what are states who are now not expanded, but they are thinking about expanding? How are they doing that? And how can you get involved if you live in one of those states that has not yet expanded Medicaid, but is thinking about it, or you think may be thinking about it in the near future? So first, the very kind of basic understanding of Medicaid is that it is health insurance for low-income people. It's health insurance for poor people. It's financed by state and federal tax dollars, different state, different financing depending on your state. But states run it, and all of those of you in the states understand that every state has its own special branded Medicaid program. You know, if you're in Wisconsin, you have Badger Care. If you're in New York, you have New York's own Medicaid, and so they like to say, you know one Medicaid program, you know one Medicaid program, and that's very true because all the state programs are different. That being said, there are really strict federal rules on how much people with Medicaid can be required to pay out of pocket. There are strict rules on what needs to be covered, on how appeals work. So even though the states do have a great deal of flexibility in their programs, there are federal rules that govern the Medicaid program. And Medicaid is accepted by most providers. I think the most recent national number I saw was 60-some-odd%. Of course, that's going to vary dramatically based on where you are in the country, if you're in a rural area or an urban area, if you're a specialist or a primary care physician. So it's hard to get a sense, you know, nationally on Medicaid providers. But our general sense is that most providers do accept Medicaid. And often, more often than not, more than half of people on Medicaid get it through a managed care organization. They get it through a private company that contracts with the state and with providers. So before the ACA, the Affordable Care Act, in order to get Medicaid, it wasn't enough that you were poor. You had to fall into a specific category. You had to be disabled, a pregnant woman, a child, or a senior, or some other special population that your state had designated. So you had to be both low income and you had to fit into a category. And the federal government, I mentioned it was funded by state and federal governments. Before the ACA, for all these categories, the federal government paid between 50 or 70% of the cost of the Medicaid program, and the state picked up the rest. After the ACA, as the ACA was written, anyone under 133% of poverty, which is about $15,500 for a single person, got Medicaid. You didn't have to be a pregnant woman or a child. You just had to be under 133% of poverty. And for this group, sometimes known as the new adult group or the expansion group, the federal government agreed to pay 100% of the cost for all states, at least for the first couple of years. So they provided this very generous federal match, much higher than what they were providing for the old kind of traditional Medicaid groups. Then the Supreme Court ruled in, and as the ACA was written, all the states would expand Medicaid, all the states would get this generous federal match. The case NFIB versus Sebelius made this expansion for states optional, and that's where has a state expanded, will a state expand comes in. Right now, we've got 28 states, and that includes the District of Columbia, that have expanded Medicaid, and we have the rest of the states making up their mind. And we have a couple of states to watch. So in Wyoming and Utah, the governors have put forth a proposal. In Indiana, we have a waiver, which I'm going to talk about in a little bit, pending with the Centers for Medicare and Medicaid Services. And in Tennessee, the governor has been saying any day now for the last several days, weeks. So there is some movement in the states, and we do think we're going to see more states expand in 2015, 2016, and onward. So just to give you a sense of who the Medicaid expansion population is, who the people we're talking about when we talk about whether a state is going to expand or not, there are about 7.5 million people who are eligible. That doesn't mean they're enrolled. It just means they're eligible for help. They're uninsured and under 133% of poverty in expansion states. Non-expansion states, about 7 million, and all 50 states, about 15 million. So new Medicaid enrollment to date, this number was as of May, 4.8. I saw a different number today that was as of September that said 9. These Medicaid numbers, and I'm going to have to put a caveat in here because I'm going to be throwing a lot of numbers at you, they are notoriously hard to pin down because Medicaid enrollment can be different month to month. Looking at census data, we actually don't have census data for the year we're in right now. So we're doing the best to kind of get a sense of who might be eligible based on data that's a few years old. But the enrollment data, I think, it tends to be pretty reasonable, and the who's eligible tends to be okay. If you see a number and you say, no, I thought I saw a number that was half that, you are more than, I welcome an email, and we can kind of talk about what kinds of numbers are out there and how many people and who they are. They're about half male, half female, and actually a lot of young people. A lot of people who maybe came off their parents' insurance, who are just getting started, and they are about half white, 20% black, 20% Latino, and 7% other or mixed race. Most of them do not have dependent children. That's not surprising because many adults with dependent children are going to fall into one of the traditional Medicaid categories, not the new expansion category. There are approximately 500,000 veterans who are uninsured and have incomes below 133% of the federal poverty level. So across the United States, there are about 553 veterans who could benefit from Medicaid. That doesn't mean they're all in states that have expanded. That doesn't mean they're all enrolled. It just means that they're there, and they could potentially be helped by the Medicaid program. We know that the new adult population has a higher prevalence of behavioral health conditions than the general population, and some of the early indicators of how the Medicaid expansion has been stretching the current delivery system is we're seeing a increase in volume at community mental health centers, and a lot of people with pent-up mental health needs enrolling in Medicaid and then seeking care. Nevertheless, from what we know, and this comes from the Urban Institute, the expansion population tends to be healthier and younger than traditional Medicaid populations. That's not surprising because remember, a traditional Medicaid population, you had to be a senior, have a disability, pregnant woman, so people who maybe might not be so healthy might skew the pool a little bit sicker, but they are still generally in poorer health than the rest of the country. Also not surprising given that they probably haven't had health insurance and might have some chronic health conditions that need addressing. So I do want to spend a bit on this potentially wonky subject because I think it's really important, and I think if you're in a state that has not expanded, this is how your state is going to expand. They're going to expand through a waiver. And so far, a part of the Social Security Act that allows the Secretary of Health and Human Services to basically ignore certain parts of the law and allow a state to kind of mess with its Medicaid program and make it look different. And that's how a state like Wyoming is saying, we're not expanding Medicaid, we're doing alternative Medicaid expansion. What they're actually doing is expanding Medicaid, but they're doing it under a waiver. And this lets the governor kind of mess around with some of the edges of the Medicaid program and craft something that maybe fits the state better and works for the population of the state, is more private market based, sort of that covers the people in the state that need health insurance, gets that federal money flowing into the state, because remember the federal government's paying for all the costs, and that's a really great thing for state budgets, but doesn't sort of expand Obamacare. So this is where we are, and we've got right now 22 states plus DC expanded, 5 states, Iowa, Arkansas, Michigan, Pennsylvania, and New Hampshire, which was kind of a little bit of a funny one, but technically, yes, New Hampshire expanded with a waiver, and 19 states who have not expanded at this time. And it is our prediction that eventually all 19 of these states will probably expand with a waiver. Maybe not in the next few years, but at some point they will all expand with a waiver. So what we're seeing in these 1115 expansion waivers are things like premium support, asking Medicaid beneficiaries to pay premiums or to pay enhanced cost sharing. It's changing the benefit structure of the Medicaid program. Medicaid has a really generous benefit package with things like transportation to doctor's visits, non-emergency transportation. So it's kind of tweaking those benefit packages. It's asking people to look for jobs or giving them work assistance, not requiring, but just offering work assistance. Health savings accounts, wellness features, basically making the Medicaid program look more like private insurance, with the idea that people will come off of Medicaid and then go into private insurance. If your state is considering a waiver and you want to be involved, and I would encourage everyone to be involved because it's a really critical issue, and it has a great impact on the type of Medicaid coverage that people in your state are going to get if they don't have Medicaid coverage right now, and they are in the new adult population. There are a lot of ways for you to get involved and to talk to your state and talk to your lawmakers about not charging high premiums, keeping cost sharing reasonable, maintaining a robust benefit package, not requiring work search and things like that, and really maintaining the integrity of the Medicaid program as something that's there to kind of catch people when they fall, low-income people, give them comprehensive health insurance, keep them healthy, and let them be sort of productive and have access to the care they need. So with that, I think I will turn it over.
Thanks so much, Andrea. We'll turn it over to Lindsay.
Great. Thank you, everyone. Thanks for having me. I wanted to provide some background about the Kentucky Primary Care Association first, and Jennifer spoke about this a little bit in the introduction. We're an association of primary care providers from across Kentucky. Our mission is to promote access to comprehensive community-oriented primary health care services for the underserved across the state. And as part of our work, we provide outreach and enrollment training systems to the federally qualified health centers and then our other members. And then we also have, as mentioned, a contract with the Kentucky Health Benefit Exchange, which is our state-based marketplace to provide in-person assisters, or in Kentucky call them connectors, to one of the regions, MCO region in the state. So I have a couple maps here. I'm going to be focused on work with the contract today. And as I mentioned, Kentucky is divided into MCO regions, and we have this one region here in the eastern corner of the state, so Region 8. This area is largely Appalachian, very rural, mountainous in places, and I'll go into some more of the demographics. Overall, the demographics really shaped our approach, and we had to be very responsive to the needs of the people in the community. So we had a population just under 500,000 in our region. In 2012, prior to the ACA rollout, the uninsured rate was 16.1%, according to the small area health insurance estimates. This region is very economically disadvantaged with, you can see 29% of the people with incomes below the federal poverty level, and then 67.2% who are considered low income, or if their incomes below 200% of the federal poverty level. So that's a majority of the region that is eligible for at least payment assistance, but a lot who are eligible for expanded Medicaid. One of the big things that shaped our approach was that 16.7% lack of basic prose literacy, and we found that many, many more struggle with reading, particularly when we're looking at the application, which has some tax language, and then with some health insurance terms specifically. So this area has some of the poorest and the least healthy counties in the state. Really high rates of smoking, obesity, heart disease, and cancer deaths. And as I said, we really try to gear our approach to the demographics, and you'll hear some of that reflected in the strategies that I'll discuss a little later. I wanted to dive right in and give just a snapshot of the first open enrollment period and what happened, because we saw a really dramatic change with this first open enrollment period. Over 80,000 people enrolled through Connect in our region alone. In the state, it was over 500,000, and currently, I think we're standing right around 600,000 that have enrolled. So in Region 8, we had 89.58% of all of those who enrolled were enrolled in Medicaid or Medicaid Expansion. Statewide, that was closer to 80%, so you can see that we had really high Medicaid enrollment. And then the uninsured rate after the open enrollment period is 7.3% across the state. So it was a really huge drop. I always like to show these maps. I think it really helps just capture really what happened. This is the uninsured rate in 2012, and is the one that is circled there. The darker the red, the higher the uninsured rate. So as you can see, we started off not with the highest uninsured rate in the state, but we're all pretty much in that red category. This is after the open enrollment period, after April 15th of 2014. And that dark there has uninsured rates less than 5%, and that was 3 of the counties in the state, and those were in our region. And then this map is as of October of 2014. 10 counties have rates of uninsured less than 5%, and there are 13 counties statewide with rates of uninsured less than 5%. It's important because, how did we get here? And as I said, the demographics of the region really did play a large role. With the low levels of income, there are a lot of people who are eligible, and when someone's enrolling, there's not much of a sell that you have to make if they're eligible for Medicaid. There's no premium, very low copay, so we're not having to go through and make a financial argument in most cases. And many times the people needed the care. For example, we saw people who had tumors and other conditions that were just going untreated because they couldn't afford care. They hadn't had insurance ever in their lives. They were never eligible for a program before. In addition to that, we went into outreach and enrollment with a strategy that ended up being really effective. We focused on a real local approach. So we subcontracted with local organizations that were already doing similar work, already had strong community ties, and we hired local folks who did the enrollment work. So in some cases, we hired from specific counties that we thought would be harder to reach. So this is the main benefit to me. Our connectors were really from their communities, and in Kentucky, that's a really big deal to be from there. The main benefit to me was that the workers saw it as a mission to improve their communities. So they were motivated to make a difference in the lives of people that they knew, and we really tried to foster this through our meetings where we discussed specific stories of the impact that people were having. In different ways, kind of just depending on the county and the area. So some areas radio was really effective, in others local newspapers, and in others it really needed to be that in-person contact. So we tracked how people heard about us by each county that they were from and used that as a guide for how to reach more people. And tracking it let us really adjust quickly. So if we saw that a radio ad was really effective, they could post another one for the next large enrollment event. And then we really found that word of mouth was the best strategy for getting people in. We encouraged our connectors to ask everyone if they knew someone else who could benefit from Connect, or if they got free or low-cost coverage, to be sure to tell their friendly that they might be able to get benefits through Connect. We asked people to share their business cards. We'd leave each of the applicants with some materials to hand out themselves. Medical providers were really great partners, and I'm going to go over some of the other partners we had, but they worked really well. In a lot of cases, they set up direct referrals. We did a lot of hospital enrollment events, set up in free clinics and health centers for enrollment. This way, we were catching people who were already identified as needing health care and health insurance, and in some cases, the referrals were written into treatment plans or follow-up plans by the providers, and that was a really great strategy. We even did events with groups that already had enrollment assisters of their own, and we kind of joined and helped boost their capacity. Here are some of our most successful messages in getting people in. We advertised Connect as a Kentucky program. We never used the Affordable Care Act or Obamacare, really, and it really depoliticized the issue. It's a very conservative area, and so we talked about Connect being our approach and the state strategy, and that made it a lot easier to get people to check it out. And that's our second message. The emphasis is on looking at your options. There's no need to enroll. There's no pressure. Just see what you might be eligible for, and we emphasized that the individual had power in deciding whether or not to enroll. Once people saw that they were eligible for Medicaid, it was really easy for them to enroll. And I do want to mention we had a single streamlined system, and that made it easier as well because they really could just fill out one application and see if what they were eligible for. We didn't have to go through 2 different systems. Advertising that in-person help was really huge, particularly because literacy levels, as I mentioned, are low in the area, and internet connectivity in some areas is spotty at best. With that, though, our connectors had to be available at all hours, after hours, weekends, really when people needed them. Because the population has a lot of health concerns, we focused on messages around the 10 essential health benefits and what that means to people. In particular, we found that substance abuse treatment was a huge draw for people to enroll, that behavioral health and substance abuse treatment has to be covered in every plan. We also emphasized the individual information. We had income charts that allowed us to do basically a really quick pre-screen and tell people what level of assistance they might be eligible for. So with just one question, we could show them, oh, it looks like you might be eligible for Medicaid. We'll fill out the application, we can see, or it looks like you might be eligible for payment assistance, or you're right on that line, so let's fill out the application and see what you could get. We made this point at outreach events that, if someone wasn't sure what they were going to do, we'd ask about pre-existing conditions or prior health experiences, maybe health emergency if they knew someone into the ER, and kind of do a mini cost-benefit analysis. So, on average, it'll cost someone $2,000 to go to the ER. What will that mean if we break it out the cost? And really making it a message of this can be something that benefits you directly. We had a really heavy emphasis on outreach. We identified early on that the best enrollment events were those that were already going on. They were not ones that we were hosting ourselves. These are places where people would already be and with organizations, in particular in rural areas. If people come down into some of the towns for certain events and you need to be there at those events because they might not come back for an appointment or for another event for a while. Our connectors were really creative, and one of our most surprising enrollment events was at a sprinkler park where I think there were 10 applications completed in one day. Some others were at check cashing or speedy cash locations, restaurants for both the workers and people going there. Our connectors were out in the community often more than in their office because seeing people face-to-face was so important. And that goes hand in hand with partnerships and collaboration. I have areas listed, but working with other groups and fostering collaboration, particularly among all of the different organizations that are doing outreach and enrollment work, was a huge key to our success. We targeted organizations that reached a broad range of people, like schools and services that were provided to them, like low food pantries and thrift stores and that sort of thing. I wanted to highlight just a couple of our outreach events. This is our connectors at the State Fair. Here we have a library where we often did enrollment days. One of our less conventional but really successful strategies was at this kind of off-the-record racetrack. We reached a lot of young invincibles there, that younger age group. We have community festivals. Here we have Chicken Fest. We did smaller events like volleyball tournaments and school sports. We'd like to go with holiday events. We have Halloween here, and recently we did some Christmas parades. We're also looking at heating assistance. LIHEAP is heating assistance, so linking with services that other people are already getting. And here we have also a picture of a food pantry. Canvassing events were really successful for us. We were just to put flyers on cards or hand out flyers outside of stores, but also our connectors would just walk into businesses and start a conversation. They found that if they called ahead and said, oh, well, can we set up a formal meeting, they didn't get such a positive response. But if they walked in, hey, do you have 5 minutes to talk to me about health insurance, they got a really warm reception. We also targeted justice-involved populations because they are often eligible for Medicaid. We did courthouse enrollment, probation and parole, and now we're getting a little bit more into jails so that we can do enrollment upon discharge. One of the things that made us unique is our focus on the whole person more than just completing applications. So our connectors really became trusted sources of information in their communities, things insurance related or not. It wasn't just completing the application and, maybe we'll see you next year to do it again. They really kept in touch with a lot of their applicants. We recognized early on that our role needed to be focused on helping people use their insurance and use health care, and that was ultimately what was going to make the program successful. So we did a lot of education, looking at health and literacy. Some of our subcontractors worked for health centers, so they could applicants about health-related programs that they were doing or that they knew about. We did a lot of work with prevention measures, using a primary care provider, and that sort of. It wasn't something that we were required to. It was just part of our approach to meet the needs of customers, and we saw that people weren't really incorporating these as people were enrolled. There wasn't someone who was responding to that, so we kind of took that on as a way to make sure that we're successful in the long run. Here are just a couple examples of what we used. Our state did this guide, How to Connect, really nicely colored brochure. We also used prevention forms that we received from the American Cancer Society and really any other resources that we could find. There was no formal process for this, like I mentioned, so we were kind of putting it together as we went along with different resources we heard about. So this is the first time that Kentucky, there was this kind of focus on enrollment to reach the Medicaid expansion population, not just the traditional Medicaid population. We needed to reach people who didn't necessarily know about Medicaid, and definitely people didn't know initially that they could be eligible for Medicaid. We also needed to reach people who had higher incomes, so we needed to cast a broad net in our outreach and advertising. That was benefited by having that single stream system. We also made an effort to enroll family members of those who enrolled in traditional Medicaid. So in some cases, we had people come in who their son needed to be re-enrolled in Medicaid, but then we talked to them about, now the whole family might be eligible. As I mentioned earlier, we focused on part-time workers whose incomes were in that range of qualifying for Medicaid, but they weren't traditionally enrolled in Medicaid. We also had a lot of, unfortunately, coal mine layoffs and worked with the unemployment office to target those who were laid off, or when we heard that in newspapers, then we would try to find those people, particularly when there were really large layoffs. People had a perception that Medicaid wasn't good coverage, so we found that we had to do a lot of education about what Medicaid is and discuss that it's quality coverage, emphasizing that it has to cover all the health benefits, the essential health benefits, and often there's a lot more than we were seeing on some of the private plans. We emphasized that there was no longer an test, which helped us to reach more farmers and others who were self-employed, but with income. So we chose these messages to educate people around Medicaid expansion and what it means now. So, the service industry is huge and really we're looking at moving towards enrolling them when they are incarcerated rather than when they are discharged. So it's a big opportunity there for the expansion population. And here's my contact information. Thank you so much.
Thank you so much, Lindsay and Andrea. So this is Jennifer Singleterry again. We'll be opening it up to questions in just a second. I've got a slide here just with some discussion questions to maybe spur your own questions. Have you, as participants on this webinar, have you done any work with Medicaid expansion in your state? What lessons have we learned here today that could apply to those of us working in public health? And how can we work with organizations that are enrolling people in coverage, like Lindsay's organization, how can we work with them to accomplish our public health goals? I heard several very interesting themes as far as who this Medicaid population is, and are they different from traditional Medicaid? I heard from both speakers, we've got a lot of the mental health population, healthier and part-time workers, unemployed, recently unemployed. Those are all some populations that have a lot of Medicaid expansion potential enrollees. We also heard a lot about low literacy rates and low health insurance literacy rates. So not a lot of understanding about health insurance. And the other theme that I just wanted to point out is Lindsay talked a lot about how they used things that already existed. So they didn't necessarily recreate the wheel when reaching out to Medicaid expansion. They went to social services that already existed, like food pantries, the unemployment office, those types of things. And again, with using events that already existed rather than creating their own. So I think those are some important lessons. So now I'm going to open it up to Q&A and also discussion. So if you have reactions to the presentations, please share those as well. You can enter a question on the Q&A box, and then Jackie, will you tell us how to do it on the phone?
Absolutely. At this time, if you would like to ask a question, please press star and 1 on your touch-tone telephone. You may withdraw your question at any time by pressing the pound key. Once again, to ask a question, please press star and 1 on your touch-tone phone. And we will pause for a few moments to allow questions to enter the queue.
Okay, great, thank you. I'm going to answer the question that we always get on a webinar is, are we going to provide the slides and a recording? We are recording this webinar and we will send out the link to it. And I haven't asked Andrea and Lindsay if we can share the actual PowerPoint, so I will ask them that, and if we can share the actual slides, we will do that too, but we will definitely have the recording sent out to you as soon as we have the link for it. And then someone also asked about email addresses, right? That's on the next slide. Is that correct? Yes. All right, so let's next slide. So here are our email addresses if you want to jot them down. Do we have any questions on the phone yet?
We do not. Again, to ask a question, please press star and 1 on your touch-tone keypad.
Okay. Well, I will take the prerogative and ask one of my questions. And Lindsay, you might get this question all the time, but why do you think Kentucky was so successful? And this is, of course, beyond Medicaid expansion into exchanges as well. But from your perspective, why do you think that contrast between the maps was just so amazing? So why?
Well, it was just a lot of things coming together. I mean, definitely we can't undersell the fact that our system worked from the start, and that really helps. From October 1st, we were able to enroll people and get them in, and obviously there were issues that came up, but we really had, we hit the ground running. We do have a state that has pretty low income, so we had a lot of people eligible for Medicaid. It was about 80% during the first open enrollment period enrolled in Medicaid expansion, so that was a huge part of it. I think that our approach, it's just very local. We've been very hands-on, targeting to our specific areas. And in Kentucky, that means a lot. I know that in Region 8, if you appear to come from Frankfort, which is where our state-based marketplace is centered, they want nothing to do with you. But because we had those local champions, they were able to really change people's minds very easily. So it's a combination of a lot of things. Unfortunately, people who really did care, and then people who were eligible for Medicaid expansion.
Great. I'm going to ask one more of my questions, and then we'll get some from online. So you showed a slide where, of some of the materials that you had kind of collected from outside groups, and as was appropriate, there's no method to this. We just grabbed what we could find. Are you part of any networks, or like how would we have gotten our public health materials to you? Is there a listserv that all of folks like you are, hopefully you understand what I'm asking.
All right, it depends and will vary between states, but here I think that we just have this information from stage when we started doing the work. So I think contacting, if it's the state-based marketplace, contacting them to see if they're willing to distribute it. I know a lot of states have statewide coalitions, and Get Covered Kentucky is our statewide coalition, so that group can distribute information. So looking for those statewide coalitions or groups. That one in particular is an advocacy group, but a lot of the assisters listen in. I do a statewide newsletter, so looking for that person in the state who is communicating with all of the assisters. That's a good strategy too, because then everyone's getting the same information. And we're all pretty hungry for it. If you even go on an organization by organization basis and say, hey, we have this resource, people are generally really happy to look at it and see if it's going to be beneficial. And a lot of times, when people have done that for us, we've just said, yes, we want it all. We want all of this information on health insurance and what is a copay and the prevention screens. So it's just putting it out there, looking for those key stakeholder groups.
Great. Jackie, any questions on the phone yet?
No, ma'am, there are not.
Okay. All right, we've got some online questions.
So our first online question is, are there any initiatives underway or planned about opioid misuse or abuse? Will you be supporting access to abuse-deterrent opiate preparations for Medicaid recipients? I'm not sure if this best goes to Andrea or Lindsay.
Either of you have any comments on that?
This is Andrea. I can say I don't know of any nationally for the Medicaid program. I know for Medicare Part D that there were some regulations about that maybe last year, and obviously we know that that's a problem nationwide, especially in rural areas, and support measures that the Medicaid program can take to cut down on abuse, and that's really kind of SAMHSA's realm. And obviously, as long as you preserve access to the drugs people need. But the short answer is I don't know of anything happening right now, and I think if it were happening, it would probably be on a more state level in the Medicaid program.
Yeah, here in Kentucky, I know that they're gearing up. I mean, it's really a conversation that's going on right now. There aren't any initiatives that are going on at the moment, but we are still working on expanding the Medicaid network for substance abuse treatment and making sure that people have access to treatment in their area, and that's going to be, in some areas, that's going to be more difficult than in others. We don't have a whole lot of services across the state. They're pretty localized around our urban centers. So that's definitely an effort here in Kentucky.
Okay, great. I've got another online question, and this seems to be directed towards Jennifer. Same thing. What about tobacco cessation? Our state's largest managed Medicaid plan allows one lifetime quit attempt.
And one lifetime quit attempt is typed in all caps. So that is unfortunate, and the Lung Association has a very strong position against those types of limits that are really not helpful to smokers who are trying to quit. And we'll say, I don't know what state you're from, but if you've got Medicaid expansion and that benefit, that one per lifetime limit, is on the Medicaid expansion benefit. So one thing Andrea didn't get totally into was the difference between what requirements there are for traditional Medicaid coverage and what requirements there are for Medicaid expansion. A whole different webinar, and I'm happy to talk you through that if you have questions. For tobacco cessation, that once per lifetime limit is unfortunately allowed in traditional Medicaid. There's nothing stopping them from doing that at the state level. For Medicaid expansion, those plans are supposed to have the essential health benefit, which has been mentioned before. And for tobacco cessation and the essential health benefit, they're supposed to be providing cessation coverage at least twice a year, according to a guidance that was published in May of 2014. And you can talk to us offline and we'll give you a whole lot more information about that. And also speculation about whether anyone's going to enforce that requirement. But if Medicaid expansion folks are being limited to once per lifetime, that shouldn't be happening. And so that's something to follow up on. Next question.
Okay, Jackie, do we have anybody holding for live questions?
Unfortunately, we do not.
Okay, well, I still have 2 more questions here, so we're good. This question, hello, we work specifically on finding uninsured children and teens and those without access to care. We are in Pennsylvania, a state that is starting to implement their waiver program. Do you have any ideas on how we can maximize the publicity around our adult Medicaid expansion program to find uninsured children and teens? Have you seen any programs addressing this in states that have already expanded? And I believe this one question is probably most appropriate for Lindsay. But Andrea, if you have anything, please jump in.
We really saw a huge amount of children and teens if you are eligible, and then we'd target places where we'd reach families. Schools, I can't say enough how beneficial they were for our outreach and enrollment strategy, because we're reaching the kids who are uninsured, those who are uninsured, who were eligible for traditional expansion and Medicaid, and then weren't enrolled, and those who are eligible for expansion. So getting them and their families. I think part of the state strategy was to have a really great marketing campaign that was child and teen friendly, but also really appealing to adults. So the marketing, I think, is great. We found in our region specifically that the real local messages and local newsletters and newspapers were the best for getting information out. We work closely with the family resource centers in each of the schools to send resources home with each child in the school, and that was really great. Again, partnering with like school nurses is another good strategy, but the publicity is not my area of expertise.
Great, thanks. So our next question, and I believe this is probably going to be more directed towards Andrea. Do you know whether any state has developed resolutions to have organizations sign on to support Medicaid expansion?
Yes. So several, I'm trying to think of states in particular that have done that. I know, who did we hear from? So I believe it may have been Nebraska. Somebody even did ballot initiatives, which, it was Wisconsin, did ballot initiatives, which generated, a lot of good publicity, but in terms of kind of moving the ball forward, I'm not sure. Having a member in your legislature, bring up a resolution and have organizations put support, absolutely. I think that's wonderful, and I think in most non-expansion states that's happening. I don't know what state you're from, so I don't know how your legislative process works or what kind of resolution exactly you're talking about, but certainly advocates in non-expansion states have been active in a variety of ways trying to get the state to expand. And the kind of best strategy, and again, this could be a whole webinar in itself, best strategy if you're looking to kind of move the needle on expansion as your state is to work with a broad coalition, work with the commerce, work with the hospital associations, public health groups, make, everybody, because the legislature is going to listen if more.
Thank you. Jackie, one last chance. Do we have anybody queued up for questions on the phone?
We do not.
Okay. One question for Lindsay. How did you decide where to target your messaging across different counties in your target region?
We initially started with just a really broad strategy and publicized everywhere. With our contract, we had to do customer satisfaction surveys with each application. So we had questions on there to ask, how did you hear us? So we had radio, newspaper, and that sort of thing. That was also separated out by county, so we could get a real quick snapshot of how people heard about us. So that, simple question really.
I did just want to mention that you will later today be receiving an evaluation survey for this webinar, so please do us a favor and fill questions, or if you want to talk more, and also look for the email in the next few days with the link to the recording of this. A lot of folks. So thanks to you both, and thank you for everyone for joining us.